Thank you, Arvind. I'm sorry I was operating on an emergency in the morning. I was running timelines and I promised myself 11 o'clock sharp. We are 6 minutes late. Friends who have joined in today for this assessment of ourselves on an awareness drive where every man needs to know about prostate health. Week after week, week after week, in the pandemic and beyond, that I've been looking into the kind of changes which is happening around. It is important for us to wake up to that phenomenon. What is prostate and what does prostate health mean? There are so many myths to actually shatter for people who may not be knowing it. And every time I have attempted to speak on this program on prostate health across right now in the pandemic online, and to colleagues and people in the society who happen to be patients who come across this very table where I'm sitting in the office at the Coquelin Hospital, I always look at empowering them with more knowledge so that more and more people become ambassadors to the subject, because sadly, things will happen one day. That means health changes which happen one day to a point in time when we are not aware of is a sad situation called an emergency. Let's not create an emergency, at least in prostate health in the country, though it is going to happen every day. In the morning, 2 people got admitted. One came with bleeding in urine since 4 o'clock in the morning. Other person came with blockage of urine where the urinary catheter or tube has been put. So we will encourage all of you in this audience today that few people were logging in and taking some time to register and log in. As a format of today's days is, I'm sure all of you are perhaps logged in, going to stay with us for next 45 minutes. The interest is for you to ask your doubts and questions. The team at Dr. Reddy's lab has been very magnanimous in attempting to connect me to you and you to me. And it feels good that we are both partners in the society on a subject where awareness is missing. And therefore, I enthuse all of you to leave your doubts, because it will be more important to answer your questions. And instead of making it a monologue, let's make it a dialogue at the end of it. So leave your questions as simple, as fruitless, as difficult, whatever you have, which are practical. Let's look at practical out here. And therefore, I would request that the society has turned so much Google doctor. And sadly, a lot of people continue to take medicines on prostate health, not knowing why are we taking, what are the parameters to know, etc., etc. So I'm going to talk on all those aspects today and actually enthuse each of you to become an ambassador in prostate health, because the next time when I talk again will be another Sunday, another day, which starts for me with emergency and ends with emergency. Friends, before I start, let me tell you that the talk I give today is one of the talks I continue to give and probably bring about changes in the society to a lot of minds which need to be changed. Sadly, a lot of graceful aging is actually turned into an emergency for the family and the individual, which should not happen. As we are in prime of life from 50s to 80s, we need to probably use and utilize the benefits of the seeds that we have sown in terms of the hard work that we have done for ourselves. I continue to speak on my YouTube channel, which goes by my name, and you could look into some other aspects of that all the time, which is more related to urinary health for children, for adults, for men, for women. Women sadly get missed out in the society, and that's not true. We need to look into them too. Men and women suffer from some common diseases, but out today we're talking about the men's health and prostate health. Prostate is a male gland. Many of my colleague general practitioners and physicians in the society do join in for such kind of awareness drives, which we need to do to the society. And they happen to be the real partners to me in this subject across. They help us out to take the subject forward to the next level, where I personally think that we are great partners in terms of identifying, and therefore all general practitioners and physicians in the society, salute to all of them. Friends, today is Children's Day, so let's come out of this and probably celebrate Children's Day today and probably spend time with them. Today also the World Diabetes Day. We need to look into all that. I carry greetings from the office where I sit in every day from morning 8 to evening 8, looking at the subject of urinary health and prostate and all aspects of urology, which includes men's health and women's health. Friends, we are here to improve today the quality of life of individuals, while we at Coquelin follow this very important motto called Every Life Matters. So greetings from this building where I sit in today, and many of you have been here, many of you are from different cities. I enthuse all of you to probably be seeing your doctors and your urologists in your cities around. For a small technical point, urologist is a doctor who specializes in urinary health. That means he takes care of the medical and surgical diseases of the kidneys, of the ureters, of the urinary bladder, of the prostate, of the external genitalia. So he takes care of the urology and the andrology, or the men's health and the sexual matters. A nephrologist is a very specialized doctor who takes care of the nephron or the kidney per se, the medical diseases, not the surgical diseases. So he takes care of the kidney failures, he takes care of the kidney toxicities, and he is a colleague of ours on the medical side. While we look at everything from bleeding to obstruction to cancer of the kidneys, prostate, ureter, urethra, bladder, everything, they look at the medical aspect of the kidney alone. That means the nephrons. So nephrologist looks at the nephrons. Nephrons are the functional unit of the kidneys. A urologist looks at your urinary health. So problems in urinary health, please see your physicians, please see your urologist in your cities. Some wake-up calls very important because I will tell you how that gets neglected. So I carry greetings on this Children's Day on prostate health awareness. Just don't forget that September was a prostate health awareness month. The whole month we spent on prostate health, making people aware. So you have got a day like a Children's Day, a World Diabetes Day as one single day to spread the awareness. And you can see the newspapers agog with all kinds of health awareness. But imagine prostate health is such an important health. We probably get forget about it. It actually goes across the whole month of awareness. And I want to wake up everybody to this aspect of prevention of diseases of the prostate or prostate issues is what my motto today would be. So it's more to bring some slides to you, only to keep you in sync and contact with the prostate issue. But I'm sure you all have questions regarding your neighbors, yourself, your elder brother and your father, and possibly futuristic issues which you have known and may not be known. So that's where the prostate is. Prostate is a male gland, a gland which actually is somewhere there deep in the perineum. Many a times people feel confused and think that what kind of issue is a prostate? So prostate is here deep inside the body. That's where the prostate is. Many times people confuse the scrotum and the testis to a prostate. So prostate is an organ that you can't see and feel yourself. It's a urologist who can feel, and only a sonologist who can see the gland when you probably go fill bladder for an ultrasonography or a sonography. So understand, this is a gland which is a small walnut-shaped, lemon-shaped gland, which is seated below the urinary bladder, and it is going to control the urinary flow. Please understand, it's like a gatekeeper to the urinary system. So if it brings about an obstruction, that's called as a bladder outflow obstruction. That means the bladder's outflow can undergo a change. And the entire subject is about this, please. Friends, it is all about a very gradual and a graceful aging happening and changes happening, which we don't know. And let's just immerse ourselves for the next 45 minutes in understanding what is going to happen to us. Next time when you pass urine and you're directing your stream, close your eyes and remember what Dr. Pandey told today. It is about looking at the urinary passage is gradually undergoing a change. As gradual as my black hairs are undergoing a gradual change to gray. So as you gracefully age from 40s to 50s and 50s to 80s, changes happen which you may not know. Some of them can cause a health hazard. One of them is this. That means the prostate undergoing a change. I did not say enlargement. I'll come to that a little later. So why does it undergo a change? Because it's a hormone-related gland. It's a hormone-related gland, like the women have got breast, which is a hormone-related gland, and it undergoes cyclical changes in pregnancy and women's reproductive years. Similarly, men's prostate is completely controlled by the hormone called testosterone. Imagine if a man has no testosterone and both the testes are removed before he goes into puberty, the prostate will not develop. If both the testes are removed early in life or are not going to function or going to be there because God forgot them perhaps, then the prostate will not develop because testosterone is required as a cascade towards development because there undergoes a change called 5-hydrotestosterone within the prostate, a benchmark of an hormone which brings about changes in the prostate. So prostate is a male gland which undergoes a change because of male hormone, and the male hormone is a requirement. Now, this changes happen from the 3rd, 4th decade silently, but it's visible to human beings from 4th, 5th decade onwards. So I see people in late 40s, 50s these days, and thereafter 60s, 70s, 80s when you're really aware of it. So we'll look at those awareness today and take it forward. So that's where the prostate is, deep inside your body, deep in the perineum, which I can examine by putting a finger in the rectum and feel the prostate about its approximate size, about the kind of dimensions, about the kind of tenderness, the pain, or the size, and sometimes a suspicion of a possible cancer. And that's what we're talking today. So the urinary passage is controlled by prostate. Otherwise, the urinary passage of men, which is approximately 18 to 20 centimeters, is different from women, where the passage is very short. We move forward. Today, you're going to know your prostate. You're going to know about the prostate. So that is the organ which is completely going to control the urinary flow, because the urine is going to come out of the bladder like that and then is going to go through the urinary passage, where a men's organ controls urinary and sexual activities. So that was annotation I did for the urethra. So let's go forward and look at what kind of complaints do people have, but unfortunately postpone day and night, postpone because something else is more important than health, because this is such a gradual process. If somebody bleeds, then he will see a doctor. If somebody gets completely blocked, then he will see a doctor. And I told you, 2 people got admitted in Kokilabein hospital today early morning because they were blocked from whole night, not able to pass urine. And this happened all sudden, which was not there perhaps to them before that, or they started bleeding in urine. So we'll come to those 2 patients and discuss about them as to 2 index cases who created an emergency. But what happens to people who complain? So let's look at who can complain. So I can complain about this to my doctor, my urologist. Doctor, I'm passing urine whole night. That means I'm getting up multiple times and passing urine. I have to search toilets, otherwise I would leak urine. I can't control urine before I reach the toilet. I pass blood in urine. I'm taking a long time to empty my bladder. I always feel I have got incomplete emptying. After I pass urine, still something is left behind, Dr. Pandey. I pass urine in the bed, which is sad news. It happens twice last week and once last month and once last year. That means something happened. I was in deep sleep, or I could not get up, or probably I was dreaming and a urine leaked out in the bed. Something which used to happen to my grandchild, or probably would happen to me in my childhood. Very important that this kind of an emergency does not happen. Dr. Pandey, I've been passing urine in drops and drops only. I pass urine 20 times a day. That means I'm able to reach the washroom and pass so many times. Holding urine is very painful in the bladder. All this tells us that there is an issue with my bladder and I'm not able to manage myself. It is important that if somebody has got these kind of complaints, bleeding in urine, not able to control urine, passing urine in drops, feels incomplete evacuation of urine, and passing urine multiple times a day, then possibly there's an issue with this and one needs to wake up to the phenomenon. So that's an important act of understanding. And any of these individuals will not know it on the day it started. So it's a gradual process. And therefore, the awareness today is to look at, can we assess ourselves better? Can we assess ourselves that there are some changes happening? If we can't assess ourselves and we are into late 40s, 48, 49, 50, and into our late 50s and 60s, so from 48, 49 onwards till the age of 70, if you have no urinary complaints, then my request would be straight away to do a health checkup. To do a health checkup where you see so many of your blood reports and this and that, at least do a PSA as a blood test, at least do a Urophometry if you are in a city or a town or a 2-tier town where a urologist is keen to do a Urophometry to know the flow of your urine and the amount of obstruction happening as a result of age-related prostate change, which is a hormone-related change. At least do a sonography. So what happens here, just to give a little lead, these kind of patients would be seeing anybody and everybody. Sadly, urology is a subject which you could be low down in the alphabetical order, dial U for urology. But a urologist is a specialized doctor in your city, in your town, in your hospital, in your locality. It is important to be a friend with a urologist after 50. The only reason is you may have urinary trouble and you may not be knowing about it. For example, let me give you a small example, which I keep giving on the YouTube channel very frequently, is that if you have a chest pain tonight, and that's the end of it. We don't need an ECG anymore. What we may require is hospitalization, emergency, ICU. A doctor may land up doing an ECG and a 2D echo, but he will perhaps do an angiography to know why there was ischemia, why the heart was probably giving you a pain, because there could be some block. And post-angiography, either you undergo angioplasty or a bypass. In other words, let's not allow ourselves to have a chest pain and then wake up to a chest phenomenon. And therefore, so much of awareness on all aspects of cardiac issues, all aspects of blood pressure and diabetes, all which are harbingers of possible cardiac diseases, which happens to very young and very old. Similarly, the ECG of a urinary system is called Urophometry. That's an ECG for me. In other words, when you pass urine in a computerized toilet outside my outpatient department from Monday to Saturday in full bladder, I know everything about you. I know where you have adjusted to, what is you're doing. In other words, that is a report card that is about your performance. And that performance is what matters, because everybody's performance, take it from me, A to Z in this country who are men, the performance is gradually going down by every month, by every year, from decade to decade. And therefore, one may not know it because it's such a small and gradual process. The process is about walking till one fine day you find that the next step is down there in an emergency of a bleeding or an obstruction or any of them, or maybe a urinary infection. So one needs to look into that I've got burning sensation in urine, I can't control urine, I've got difficulty in passing urine, my urine comes in drops, and I probably think I've not emptied my urine. If all these are happening to anybody in the society of whose you are an ambassador of, in terms of your own WhatsApp group, your own society, your own senior citizen friends, your fathers and your elder brothers, and probably your colleagues in your workplace, it is important to wake up to this, because it is something so much shrouded in shame. We are always anxious and worried about कौन urine की बात करेगा, urine तो सुसु और shame की बात है, लेकिन एक दिन जिस दिन आपको वो तंग करता है, उस दिन आप शायद उतने capable नहीं रहते. Let's go to the next level. Just give you some examples before I go forward. These are my pet examples because all rotates around this. Dr. Pandey, I take a long time to start urination. So if he's a young man, imagine if he's in his 20s, 30s, and 40s and says, Dr. Pandey, I take a long time, my bladder is full, I reach the toilet and take a long time to start urine, then there's possibly a block somewhere already. And that is not the age when the prostate is going to grow and cause an obstruction. So possibly there has been injury, there has been a trauma, the urethra, an organ through which urine comes out of the body, can also undergo a disease process. And that is something we need to know. Because I deal with urethral strictures or blockage in urinary pipe of both men and women, I know that urethral blockage or urethral stricture is a disease that we need to make people aware about. And that is extremely important. So blockage in the urethra in young men may give them hesitancy or not able to empty their urine completely. Number two, elderly men. And now elderly does not really mean elderly, but people who are more experienced men, I would say experienced from their 50s, 60s, and 70s and 80s. The prostate is enlarging. Enlargement may not always be seen on an ultrasound in terms of the size of the gland, but enlargement can also happen by choking the urinary passage internally. So an internal enlargement of the prostate, bringing about a blockage in the urinary passage, is actually crux of the matter. Take it from me today. That means we're not looking at the prostatic size. For example, let's get in here before I go to the next example. A 20 grams prostate can still cause blockage in the urinary passage internally, because the urinary passage of all of us, including you and me, is a very narrow and a thin passage. When we look at the tip of our organ, we know how thick or how open is the urinary passage. That's what God gave us. If that is what the urinary passage is, it can get blocked by minimal amount of occlusion internally. A urethra can undergo a stricture, or a small stone can come and block it, or possibly the prostate decided to enlarge internally and fool Dr. Pandey and fool the sonologist that they would say it's not enlarged. So enlargement is not my main worry. My main worry is an occlusion internally. So a 20 grams prostate can still occlude internally and block. एक दरवाजा अंदर से रास्ते को बंद कर सकता है. That's a possibility. Compared to a possibility of a very large prostate, which on sonography is seen as 100 grams and a 200 gram prostate, but may not block the urinary passage. Are you getting my point? So this is where we are getting into an understanding that the blockages in urine is something that possibly will be required to be identified by you in the society. If you pick it up early, things get easy. For example, somebody has a 20 grams prostate, but takes a long time to start urine. And somebody has got 100 grams prostate and takes a long time to start urine. That means the urinary passage is occluding. The bladder needs to generate more pressure to overcome the resistance that could be required to bypass this enlarged prostate. And that is where it comes to. This is called hesitancy or taking time to start urination. Very, very important. I think this is what we talk to our patients and ask them questions. पेशाब खुल के आती है क्या, टाइम लगता है शुरू करने में, धार कैसी है, वगैरह वगैरह. So when we ask those questions, we really ask them, do you take a long time to start? And some people say, Pandey, once I start, I'm able to pass. But starting is such a difficult aspect. I'm just not able to start urination. These are important aspects. Number one. So remember, the prostatic enlargement measured by the ultrasound is not the real benchmark of your problems or your trouble. Your main problem is your complaints or the amount of occlusion happening internally. So if you can assess yourself and you are the best judge for your own body, good enough. If you can't assess yourself because it is, as Dr. Pandey said, a graceful, gradual aging, millimeter by millimeter, I can't assess. And you've got some other complaints too. See a urologist in your city, your town. I see people from morning 8:30 till night 8. And I understand that all my colleagues in urology do a similar kind of work in identifying you and helping you out of the complaint. So that was the first complaint. Let's go to somebody else. I've been experiencing bleeding in my urination. That possibly was ignored by one and all because it was investigated, not much was picked up, or the bleeding stopped on its own and everything is fine. But that is not true. If you have got bleeding in urine, which could be bleeding from the undergarments when you get up at night, which is called urethroragia, or you pass urine and from beginning to end, everything is urine, or only the end is blood, but the rest is probably urination, or everything is mixed in one. Kindly don't ignore urine and bleeding at all. We should never leave this important aspect at all. So for me, it's an important aspect to make everybody understand that this should not be an emergency created by anybody in the world. It can happen, possibly because more and more individuals in that age group where we have our audience today would have been patients of cardiac diseases, where you get ecosprin, where you get clopidogrel, which are wonderful drugs to keep your heart and your stent moving. These are also blood thinners. And many patients could bleed in urine, bleed anywhere and everywhere in the body because of the dosages or possibly changes happening. So bleeding in urine is not necessarily because of ecosprin or clopidogrel, but these are blood thinners. In a susceptible individual who has got a urinary infection, susceptible individual who has got a cancer in the urinary passage, or somebody whose prostate is enlarging, and enlargement of prostate comes with more and more blood supply, could just bleed in urine. If any of these is happening, then possibly there is an issue which we need to know about. So don't take any bleeding in urine lightly. In other words, the bleeding that you can see. So urination, bleeding in the beginning, bleeding at end, bleeding at all is something which you need to look into. All episodes of bleeding should be finally taken to a urologist only in your city. In other words, if you continue to be seeing my colleagues, even if their bleeding is happening, we may be missing out something. Don't think that you drank less water or it's a summer season and bleeding has happened. It's not a nasal bleed where you put a finger to pick your nose and you bleed around, etc., etc. So bleeding always has a cause, and the cause has to be gone to a logical conclusion. Either it's a stone, it's an infection, or it's a prostate changes of enlargement and therefore more blood supply to the prostate, or a cancer sitting anywhere in the urinary passage, of which a urologist is qualified to take care of you as soon as possible. So let's not postpone our health on that aspect. Bleeding in urine, never to be taken lightly. Bleeding of any kind. Number one. Number two is, there's something called as microscopic hematuria. When you do a urine test, many a times you see there are RBCs which are more than normal, but you can't see them in urine. My urine is clear, but the urine report always shows microscopic hematuria. Out here, there are two things which I want to point out. Number one, how do you give a urine sample? So urine sample is always given as a midstream and a clean cat specimen. You need to pull the skin back. If you are non-circumcised male, the prepuce or the skin always harbors bacteria, always harbors extra amount of bacteria and fungus, which you need to maintain a great hygiene of all the day, every time you take a bath. Number two, you should always pull your skin back, wash it up very well. Your bladder is full, you start passing urine, and the first part of urine does not go to the bottle. Only the middle part of urine goes to the bottle. And therefore, in English, we call it as a midstream and a clean cat specimen without touching the bottle. If you have been giving your urine specimen other than this, you've been giving a wrong specimen all your life. Not necessarily you have to get up in the morning at 6 o'clock and give a urine sample, though it's preferable. If you see me now at 10 o'clock in the morning on a Sunday, you will give the urine sample right away. And that is what I aim for. I aim for an awareness where you need to know how to give a urine sample. Doctors in this city, country may be busy enough with next and next patient and emergencies and the kind of work they have done as warriors in this pandemic. I don't blame them for having not been able to tell all our patients how to give a urine sample. But all the urine samples have to be a midstream and a clean cat specimen, a specimen which behoves the right kind of specimen given. It's not a blood sample that we will draw in a lab or in a hospital. It's a sample given by you. And therefore, you need to know this. For women, they should clean the lower part or the introitus very well. The bladder should be full. They start passing urine. Women have difficulty aiming the urinary stream down there, but they will pass the middle part of urine in the bottle, which is a midstream and a clean cat specimen. Similarly, all men always remember, pull your skin back, wash up the whole area very well, keep the skin away, pass urine, middle part of urine only goes to the bottle. Else you have done injustice to yourself and your doctor has landed up treating your urine cultures, which are mixed growth or the growth of those bacteria which have been brought out of the phimotic sac of the tight prepuce or the skin which has not been circumcised, and we probably have been treating you wrongly many a times. So this is a wake-up call for us to look into how to give a urine sample, not to ignore urinary complaints and necessarily not to ignore bleeding around. Somewhere there's a cause. So microscopic hematuria can come from the kidneys. Many a times we involve our nephrologist. Microscopic hematuria can come from a stone, can come from a UTI, can come from a prostate which is enlarged, which will then start shedding blood. Or it could come from the tip of your penis where the skin or the prepuce is too tight, and that's called phimosis, which you have been sitting around because you're not utilizing your organ for other functions that it needs to be done. That is an important slide, and I want to wake up to it. Passing urine multiple times at night. So remember, once or twice you may get up to pass urine in night. This is an important subject because out here at the Kokilaben Hospital in the Department of Urology, the team out in the Department of Urology on the second floor runs this important clinic called Nocturia and Bedwetting Clinic. Please wake up to this phenomenon. Nocturia, on which I have talked umpteen times on the YouTube channel, getting up multiple times at night is a phenomena which happens in prostatism. So men in their prime of life may get up multiple times at night. So let me just give you a little insight on this important slide. Normally you get up once or twice at night and don't panic about it. It's possibly because age is gracefully changing, there are hormones changing too. The arginine vasopressin mechanism, a mechanism which works on the kidneys, brains, the brain and the bladder cycle, is something goes a little haywire, as a result of which the urine possibly is produced more at night. Sometimes it could be more than 33% of the total urine production, which we call as nocturnal polyuria. That means you're producing more urine at night. So getting up multiple times at night is not uncommon phenomenon. And when this happens, it's a trouble phenomena because you have to get up, you have to go and pass urine. And many people, our fathers and grandfathers in their 70s, 80s, and 90s, also have issues about getting up, about falling down, about having Parkinsonism and arthritis and issues around. So all of us are gracefully aging towards the destination. And we may have issues with mobility, activity, lights, night, and probably getting up. So it's an important issue for all elderly people getting up multiple times at night. But it can happen at my age of 50 also, where people get up few times at night. And that actually becomes bothersome the next day. The next day, you are still awake because your sleep was broken. Many times you may not get a good sleep. And therefore, nocturia or getting up multiple times a night, a subject which I run with strong degree of passion, which I see every day here. People come and complain. But the pandemic only complaint is getting up multiple times at night. Daytime, I'm good. I don't leave the daytime alone because he says good. I still investigate his prostate. I still look at his PSA. I look at the Urophometry or the ECG of the bladder. But I make it a point that you are not missed out on any aspect which is non-bothersome to you because you wake up to a bothersomeness of multiple times at night. Unfortunately, believe me, nocturia is one of the commonest lower urinary tract symptoms, which sadly has been brushed under the carpet because either the patient did not complain, or the doctor did not know how to treat, or he did not tell the right doctor, etc., etc. So many times people continue to live at getting up multiple times at night in the prime of life, and sadly are missed out completely. Extremely important prostate issue. Women do get the same thing. Young people do get. But in prostate health, it's important for you to know. Getting up multiple times at night is also an issue of prostatism. Very important. Getting up multiple times in the daytime, going again and again to pass urine, bothers you so much that you probably want to see a doctor as soon as possible. Nighttime, you somehow adjust, you don't know whom to go to, you sometimes complain, you wear a diapers, or you stop drinking water. So out here, the issues that we like to discuss is cut down your water intake at night. I tell everybody, I tell all the Pandes and Das and Mahapatras and Mohantis that please become a Jain from tomorrow. In other words, drink and eat for the first 12 hours of the day and think you're living in a village with only lanterns and candles. The next 12 hours of the day is more of detoxification and regeneration. And therefore, sleep early, sleep long, and possibly don't get up multiple times at night. So at the behavioral therapy of nocturia is to cut down your water intake in the night. Not only water, tea, coffee, alcohol are all diuretics. You hammer your kidney with more amount of fluid, which produces more amount of urine. So your job is not to do with kidneys around. Kidneys are independent organs, even if they are inside your body. Your job is to look at when the bladder fills up, then is your role coming in. The role play that you do is empty your bladder, which sadly is undergoing a bladder outflow obstruction because the prostate is undergoing a change. And prostate is undergoing a change for everybody. For me, for the prime minister, for the minister, for the governor, for everybody. Nobody would escape it. Because it's happening, we need to wake up to it and bring about a complaint which we have. If you have a complaint, we don't sit on it just because today is Diwali, tomorrow is Holi, then there's a new year, then there's a marriage, and then there are social functions. One cannot link a social function with a medical function together. I continue doing all the time. People say, "Aaj raat ko hum America ja rahe hain. Aaj raat ko hum Dubai ja rahe hain. Ab aapko pehli baar dikha rahe hain." And the time they come, they're almost coming in a semi-emergency to me. So I would look at, don't wake up to a phenomena of semi-emergency of not able to pass, bleeding in urine, having severe symptoms, but now that we have to travel, we wake up to it. So it's important similarly that don't have improper sleep, don't leak urine in the bed at night because this has got your own stigma. You live in a morale of a different kind. You're searching for the right doctor. Similarly, your children and grandchildren who are between 9 to 15 or 6 to 15 years and they are bedwetting, it's not normal and usual. Don't leave them to continue to bedwet when they become adolescent and they continue to then become adult. They will blame you for this. Sadly, these are all treatable, but these are so much brushed under the undercarpet. So enuresis or bedwetting and nocturia are treatable phenomena. That we're talking today of adult men, nocturia or getting up at times, multiple times a night is also an issue of prostatism, which we need to wake up. Let's go to somebody who has got straining in urine for the last 20 years and had a road traffic accident then. Very classical. If he had a road traffic accident and some issues in urinary aspect, he developed perhaps something called a stricture or blockage in the urinary passage or urethra. If that is what has happened, he has got obstructive voiding symptom for 20 long years. He woke up to a talk or an awareness that you and I did today, and he says that I have got trouble. All that I do is I do an ECG of the bladder, which is called Urophometry. Uroflowmetry. Metry is measurement, flow is speed, and Euro is urine. Please don't forget this word. This is an important test, a test which tells me all about you. So when you, in your full bladder, pass urine in a computerized toilet, I get to know the reality about what is happening to the prostate, related changes that you possibly have missed out or you are complaining. So Uroflometry gives us an idea about the straining pattern, the obstructed pattern, the kind of flow, and immediately thereafter we check the residual volume. So imagine Uroflometry is stronger than ultrasound. On an ultrasound, you only get to know the prostatic size. You got to know the bladder wall thickness. You get to know if there's any kidney swelling. You get to know are there any stones anywhere. But your sonologist asks you to go and pass urine in the toilet. What you do in the toilet is what is Dr. Pandey interested in, or what your future is about. So your future or your entire placard will depend on how you pass urine. And that can only be measured when you pass urine in a computerized toilet, or you complain about that to your doctor, the way he picks it up. That's important. So post-Urophometry, we do a post-void residue to know what is left in the bladder. And that tells everything around. So one test that defines everybody from his 50s to 80s about his urinary health is Urophometry. Accessory tests are a PSA and obviously a sonography. The PSA is very closely matched with my finger examination. We'll come to that. Friends, we are talking about a prostate gland. That's the entry of the prostate. This video may not play. We will move forward on that. I'll come to that if required, if we have got time. The old paradigm was small prostate, thin bladder wall, no trouble will happen. That is not a reality. The old paradigm was enlarged prostate, thick bladder wall is the only man whom we need to treat. Don't forget that men don't grow old just because their age becomes 80. There are many men who are younger than me at the age of 80 because they feel young. They are doing young. The bodies have been preserved well. They were of that era where everything was fine. So old man or 80 years man is not necessarily old. I want to enthuse that very well. And a 50 years man is not necessarily young. In other words, we all are young at heart. We all want to be young, but the body undergoes a change. Something which does not come by your permission or your understanding. It's an internal phenomenon. So small the prostate can still block the urinary passage by only blocking that urinary passage. Imagine what God gave you. I'm annotating that in red. So that is the only amount of passage which has to be blocked. It can block internally. This is an old paradigm. The larger the prostate, more the blockage, smaller the prostate, less the blockage. The story is over. That's not true. Yeah. Subsequent paradigm is a small prostate with alpha receptors or with an internal blockage can bring about a blockage in the urinary passage. And that is an important aspect to wake up today. So normal prostate is 10, 15, 20 grams. The prostate can undergo a size as big as 100 grams, 200 grams, even 500 grams. But it grew to that size. Please ask a question to yourself. It grew to that size silently, only because it was growing without your knowledge, growing without a complaint. Therefore, it can grow externally to very large size without blocking internally. And that is where the crux of the matter is. The current paradigm is to understand the prostate and to understand many aspects. I'm not going deep into it today because I'm trying to enthuse you with slides to make you understand that prostatism is something which I need to take it to the next level. So to me, it is important to wake up that there are three kinds of diseases we suffer in the prostate. One is called prostatitis. Any itis is actually an inflammation. Appendicitis, glossitis, similarly prostatitis. Young men do suffer from it. Elderly and middle-aged also suffer from it. Prostatitis or inflammation of the prostate, which can cause by inflammation or infection, where a prostate will be swollen, will be all inflamed, there'll be pain, there'll be discomfort, there'll be bleeding, there will be difficulty in passing urine of a sudden onset. This can happen because of an infection. A urinary infection can cause it. In a younger man, it's more common post-sexual activity, but in middle-aged and elderly people where prostate is enlarging, the urine is not emptying completely, infection can happen in the prostate, which is a solid organ. Like infection in the kidney, or inflammation of the kidney is called pyronephritis, where the kidney is got inflamed. And how did it get inflamed? If it is hidden deep inside our rib cage. It got inflamed by an ascending urinary infection, which happens because of straining, pushing. I'm a diabetic. My diabetes is uncontrolled. I am a woman. And the urine goes all the way up. Similarly, men can have a pyelonephritis because of a blockage, because of an acute infection spreading up. But we're coming to prostatitis and not pyelonephritis right now. Prostatitis is inflammation of the prostate where you have sudden onset, pain in the perineum, difficulty in passing, burning, fever, and all this is in the background of a possible obstruction of urinary flow in the past, or a sudden onset change in a young man post a sexual activity where the whole thing is inflamed. Prostatitis requires supportive treatment, antibiotic therapy, looking at urine not getting blocked completely, giving the medications to cut down the inflammation, which could even require hospitalization and injectable antibiotics or prolonged oral antibiotics to treat this acute prostatitis and not let it go to a chronic prostatitis, which again is a difficult challenge to handle. And I see a lot of chronic prostatitis coming up. Friends, we're talking about prostate health, and the most common problem on the age group side, silently happening to colleagues in society, many of you are logged in today, is about enlargement of the prostate, not externally all the time, but also internally. That means the prostate undergoes a benign prostatic hyperplasia, hypertrophy, or enlargement internally, which I said virtually happens to all men over 50. Nobody escapes it. So I won't escape in my next 10, 20 years, and as such, nobody. But it does not make a difference. If our hairs turn gray, we don't mind it. It's okay. It's graceful aging. But if it brings about a change that you identify today after this talk, or you know it already, and I have got 5 to 10% of my patients who are doctors and doctors' relatives too. whom I know personally as my colleagues in the city, do also land up here from various specialties saying, Dr. Pandey, we heard you and we understood that our flow was not good. We were probably postponing it or only taking medicines to get well. So why do people take prostate medicines forever without knowing the result? Would you take paracetamol forever just because you had a fever today? No. So if you had a urinary complaint and your doctor saw you, whoever the doctor was, he gave you a medicine and you improved, would you stop the medicine? Would you not stop the medicine? How will you continue? What are the parameters to continue is important. So benign prostatic enlargement or prostatic hyperplasia comes with symptoms of difficulty in urination, and it tends to increase with age. So initial difficulty, you may adjust, your body adjusts and you don't complain. But the difficulties which come later, which you wake up to, or you've been waking up but postponing because every doctor would operate you, which is not true. It is important for us to wake up to that phenomenon. So prostate changes can be troublesome. And this is the common disease or crux of the matter where a lot of colleagues have joined as an audience because they say my urinary flow is absolutely good, Dr. Pandey. I say, please go and do me a Urophometry. And I know the reality of a student who says, I'm a very good student at home. But when he goes to the examination hall, the reality of his examination result comes as the graph of a Urophometry, which I call as ECG of the bladder. So I'm waking you up again and again to this important issue that prostatic enlargement by size is not a very big worry to a urologist. The prostatic enlargement internally by causing an occlusion to the urinary passage is the crux of the matter. The earlier we wake up to it as a society, as all men, I think we wake up to a phenomena that any kind of a complaint in urine, I'll pick up early. And obviously, I enthuse individuals who are in their 50s and beyond and have no urinary complaints. Kindly go ahead and get a sonography done. Look at the internal aspects of an indirect or maybe an imaging procedure only. It will wake you up to changes happening internally. It will also wake you up to see a urologist. It will wake you up to do a Urophometry and a serum PSA. And a urologist will not only see the reports, he is the first person to ask you those X number of questions, which gives us an idea. Are you getting up multiple times day or night? Are you passing urine with a good speed? Are you able to paint the wall in front of you with the urine flow that you had in your childhood? Or the urine is passing on your feet, on your clothes, and you get wet every time you pass urine? Can you control urine or can you not control urine? Do you empty your bladder well or your bladder urine stays back and you know that you're not emptied, but you still come out because that is all you can do in one go? Do you go twice? All these things tell us an idea that men have been postponing urinary health and have been unfortunately taking medicines without knowing the improvement of it. So it's a wake-up call for the improvement, and that's the awareness we're waking up to. And finally, the third disease after prostatitis and BPH is prostate cancer. I told you that prostate is a male gland seated deep inside, undergoing a change decade by decade with hormones. One direction it is taking directly is towards enlargement and obstruction. The other direction it could take is a cancerous change. Other than your hair and nail, I think everything in the body can undergo a change towards possible cancer. And therefore, we need to be aware that symptoms of cancer don't come with a knowledge or probably a sound or always a complaint. It possibly a prostate can undergo a change, and the change can be silent, or the change can be completely loud in terms of obstruction to the flow of urine, bleeding in urine, and it could even be a cancerous change. Of those 39 patients I saw yesterday, 3 were cancer prostates on my finger examination. When I examined them through the rectum and touched the prostate, these were irregular, asymmetrical, hard, fixed prostates. Men were either on medicines for prostate diseases for a few years to few decades, or had come with complaints of bleeding and urination. So 3 patients out of 39 yesterday on a Saturday, a weekday, we saw which looked like cancerous prostate changes around. So the prostate cancer can be picked up by a urologist earlier than you, because you undergo a health checkup, you undergo those changes, and somebody wants to pick it up. The only good news about prostate cancer is it's completely curable. People whom I treated 20 years ago, 5 years ago, and last year also, whom I cured completely of a localized disease, is cured forever. And that's one reason why the world celebrates prostate health awareness from September 1st to September 30th as one full month. And that's what I celebrated on my YouTube channel, making people aware on various aspects which you could listen to at the end of the program and beyond, to enthuse yourself as ambassadors on the subject of prostate. So prostate cancer, the word cancer strikes hard. The prostate cancer comes with various grades. All that we look forward to in these awareness points is, if you have a complaint, we pick up a prostatic enlargement, we pick up a urinary complaint, we pick up a prostatic changes, or we pick up a prostate cancer, anything early. Prostate cancer is not so common, but remember, it's the 4th commonest cancer of men in India. So it's not so uncommon. Men do suffer from it. Now let's give you some good news about it. At the age of 80 years, 80% people will have gray hairs. They will all be having gray hairs, and you can tell them that they're 80 years young or 80 years old. Sare baal pak gaye hain. Similarly, at the age of 80 years, 80% people will have cancer prostate sitting inside their prostate. That means the prostate, a male gland sitting inside, not bothering him and his family. He's living a good life of working, traveling, retirement, eased, looking at webinars. He will have a silent cancer prostate sitting inside, like he could have a cardiac blockage sitting inside, not bothering him. His quality of life is not disturbed in his walking, running, jumping, passing urine, no bleeding in urine. But when he comes to a urologist at the age of 80 for some reason, I examine him, I go to the thorough evaluation, it could be a cancer prostate sitting in. So he would not die of cancer prostate. That means the cancer prostate is also a part of the evolution of changes which happens as a result of the lineage of the cells which undergo. And many people in their 80s and 90s can have cancer prostate. We don't worry about them. We tell them this is a very indolent disease, a very mild disease. So at the age of 80, 90, and 100, if you have a cancer prostate, don't panic too much. There's a doctor sitting there who would counsel you as a urologist. And I do that quite often across the table, making people aware that why worry if there's somebody in. I told you that become friends with your urologist in your city, your town, and in your country. So that you are 50 years young, and beyond that, changes will happen. Friends, let's look at the myths which I was talking about to bring about a closure of the program very soon. To take your questions. Number one, larger the prostate, more the obstruction. That's a big myth. That's a big myth, and please take it home. Take a picture of this and you remember that larger the prostate, more the obstruction may not be true. May not be true. That means smaller the prostate, there could be equal or more amount of obstruction. Obstruction is a phenomena which is surmised so much by you, so much measured. So once you complain, we measure it. And therefore you need to complain. Silence of such kind of a menace is not acceptable, and therefore the awareness on a Sunday, after we work 6 days a week on a 7th day, to enthuse each of you to know that prostate size does not matter. Prostatic obstruction to the urinary passage matters. That could be the bottom line. Number one, only elderly men get prostate cancer or prostate diseases. Not true. I've had people whom have done a radical robotic prostatectomy for cancer prostate in their age group, anything from late 40s, 50s, 60s, 70s. So not old men get prostate cancer. But as I said, 80% men at the age of 80 years may have cancer prostate sitting inside and not troubling them, and they will never get troubled. They would probably gracefully age and die of other reasons and leave for heavenly abode, but not because of the trouble with a prostate cancer. So elderly men may have prostate cancer, and elderly men are doing very well. They have set the ball rolling with fundamentals in the country and for the family, and we respect them for not having complained, because there was no complaint. But men in their 50s, 60s having postponed their urinary health or having postponed complaints is a dangerous thing. We'll come to that. Small prostate need not be treated is a wrong thing. For those who undergo a fancy health checkup every year and undergo a prostate size and measure their PSA and carry a good notebook written every year, I measure the prostate size and prostate and PSA level. I don't think we should look into that. A small prostate can obstruct you quite dramatically, and you may not agree to it, and maybe your family doctor may not agree to it many a times, and we will be at variance of understanding. And that's for you. A small or a large prostate has no meaning. I'm reiterating again. PSA testing is not beneficial. Somebody says that's not true. PSA is a surrogate marker. We'll come to that. But PSA is a surrogate marker. It's not a direct marker. PSA is not a direct marker of cancer prostate. Let me be very clear about that. We'll come to that. So PSA testing is beneficial, both in screening, also yearly after the age of 50. And after your urologist has seen you, he will ask for a PSA. If you do a random PSA or PSA when there's a blockage of urine, when there's a prostatitis, then I think there is a change happening around. In inflammation, in infection, the PSA can go dramatically rising around. We'll come to that in a question or two. Prostate cancer is always curable. That's a myth. In the era when I trained myself in CMC Vellore and Jipmo Pondicherry, and before that in Orissa, in my BBS MS days, and beyond that, you know, that era was not about such kind of awareness at all in the society, where you all are empowered today to know all about prostate over the whole month of September and 365 days a year. In that era, people used to come with an advanced prostate cancer. They still do come. Not everybody is benefited from the talk that I'm able to give. Though I keep a lot of offline and a lot of issues happening on the YouTube for people to read it and listen to it from various cities and countries. But there was not so much awareness in that era. And there was no awareness meant directly that there was a prostate cancer which nobody knew till the urine was completely blocked, till they had bleeding, or till it spread to the bones, and they had a fracture or a spine compression and they were paralyzed, or it spread somewhere to the liver and probably to other organs and lymph nodes. And so there were very advanced prostates coming in that era where we could not cure. Today's entire aspect of change in the society adapted to Google and picked up things early. Society adapted and understood that prostate cancer runs in first-degree relatives, and therefore all fathers who have got prostate cancers, their sons are aware today that they could get a prostate cancer as they are at higher risk compared to anybody else in the society. So all first degree prostate cancer relatives need to be evaluated by the urologist very closely for urinary health and for a possible prostate cancer pickup earlier around, because it is more common in first degree relatives. So prostate cancer is not always curable, friends. And that is why I'm waking you up today to an important aspect of your prostate cancers pick up early and localized. I do something called robotic cancer prostate. We remove the entire prostate in that situation by a robot. The prostate is not there because the whole organ has been removed by a robotic surgery, and that's the end of it. The cancer is over. But if you come late and it has spread beyond it to the rectum, to the side walls, the pelvis, gone into the lymph nodes, metastasized, and has become a higher stage, then possibly we can't cure you. But still, there's a good news. The good news is prostate cancer is a hormone-related gland. It's a hormone-related gland story, which means we can manipulate the hormones and can cut down the cancer burden where it does not bother you. So I have close to 7,000 to 8,000 prostate cancer patients personally across the country who are under treatment with me, but are spread disease. What does it mean? They're all alive. They're all doing well. The longest surviving prostate cancer after having been diagnosed as an advanced prostate cancer to me was in my college days. He's still alive. He was only 49 at that point in time. 26 years later, when I was in my general surgery days, he is still alive even after having the prostate cancer spread. So he was a low-grade prostate cancer which had spread. All the hormone therapies and everything brought him down, and he is on a yearly follow-up. And this is not an uncommon story. Prostate cancer advanced and spread, you can still survive for 2 years to 10 years and more, depending on the kind of grade, depending on the kind of medical management, the kind of work that we do on hormone manipulations and the new medicines which have come. So prostate cancer is not always a killer at the middle and early, even if it has spread. And therefore, don't lose hope if you have or relatives have a prostate cancer. There is so much happening right now. So we leave prostate cancer and the scare of prostate cancer because that is a manipulable and a completely treatable and a curable disease. Now, the other myth in prostate is surgery is my only treatment option, and that's not true. Just because this myth has been floated across the world, people don't want to see a urologist. They want to take Ayurveda, they want to take homeopathy, they want to go to their elderly group of friends and talk about aur kya lete ho aap, etc. But that is not true. Surgery is not the only treatment option. 25 years ago, there were no medicines. Everybody underwent a surgery or lived a life on a catheter. Today, surgery is a wonderful option. You're dealing with a possible surgical disease. But yes, today we are spoiled for choice with wonderful medicines which can change the very natural history of aging of the prostate. And how amazing is science been and scientists been across, how amazing pharma companies been to having brought the best of the medicines to the land of India, which is important. Wake up to this phenomenon that surgery is not my treatment option as a urologist. My option for surgery has gone down dramatically. I used to operate these many people before. Now I operate only these many. What it means around that the prostate undergoing a change, you are the game changer. You can actually help yourself by seeing your doctor early. He can do so many things. Number one, he can pick up your complaints. He can stratify and quantify your complaints by the right kind of tests required. He would then probably put you on the therapy or put you on a conservative management. If your flow is very good and the prostate is small, he may possibly give you nothing but ask you to come in 6 months' time, or if you have any urinary complaints. If you come in 6 months' time, there are no complaints, or there's a change in the flow, he will make you explain that the flow is gradually going down, and you would say, I could not know it. In that situation, he would put you on a medical management. Surgery is not my only treatment option then. Number one. Number two, prostate is undergoing an enlargement of the prostate that you study so well. How? By knowing the prostatic size on a sonography, which you do yearly, otherwise too. That prostate size can actually be shrunk. It can be attempted to be shrunk because it's dihydrotestosterone change happening around. And we have got two drugs today, dutasteride and finasteride, not today, but for the last 2 decades, which actually bring about a change in terms of shrinkage of the gland. So your prostate can be made to shrink. Your age cannot be made to shrink. I can do nothing on your age or changes that happens in your bank balance and stuff in your life around. But I can bring about a prostatic change in terms of attempting to shrink your prostate gland. And what a wow. That means you may gracefully age and become experienced or elderly in the society. Your prostate will become younger and younger. Isn't that a great change which can be done? So surgery is not my treatment option then. And therefore, one needs to see his urologist if his prostate is enlarging. One needs to see if the urinary complaints are significant or if there are no complaints. We stratify you by those invisible tests where you write an exam called the Urophometry. And once you pass urine, the computerized storage, we know everything. But friends, when did we operate anybody for fever? When did you operate anybody for corona or for malaria or for filaria? We never operated people for medical diseases. So prostate enlargement and occlusion and blockage is a surgical phenomenon. That means it's an obstruction. When will I do something to open the door, which is getting closed every minute, and finally will get completely closed? I have to open the door. So opening of the door today can be done medically if you come in time. If you come late, like the 2 people getting admitted today, one with obstruction completely and had not undergone treatment as it gradually changed to one fine day he woke up today morning. The other person who has blood in urine and the prostate is looking hard and completely occlusive and there are clots inside. That means he has bled and caused a complication. And surgery is my only treatment option. So today, we do surgery for only a handful of indications, but we treat a very large group of patients on medical management because patients are aware or society is aware about the prostate health. It's such an important issue. Now, Psa testing can be done in retention of urine or acute urinary symptoms. No, please. PSA is a very sensitive marker. A very, very sensitive marker. PSA stands for prostate specific antigen, a blood test that we preferably take in a fasting state. And if you are going to do a PSA in a time when you have urinary retention of urine, when the prostate is undergoing a hammering, or there's an acute severe prostatitis and infection, the PSA, which is normally 0 to 4 nanogram percent, may come as 20, 40, 60, or 100. And you will be confused because the world thinks PSA is a marker of prostate cancer. Whereas we know a PSA is a surrogate marker of prostate organ. It's an organ specific marker, not a disease specific marker. That means PSA can rise in many diseases. And one of the diseases is cancer prostate. The more common disease today in India is chronic prostatitis or prostatic inflammation, because prostate is like a honeycomb. It's actually like a honeycomb. Madhumaki ka chhatta. Gradually it can increase because more and more honey is being placed as a result of graceful aging, and that can swell it up because all the honeybees gradually grew the prostate into multiple more cells and each cell was swelling because of more honey. So like a honeybee, it's like a prostate is like a gland which is gradually enlarging because it's being fed with the hormones, and you can handle it completely. So PSA testing is not to be done in retention of urine or acute retention. That means if you have got urinary infection, burning in urine, not able to pass, a lot of straining, and there is fever infection, you do a PSA, PSA will be very high and you will panic around and somebody will just land up doing biopsies for that, no reason around. I said PSA is not just for cancer. PSA is a serine protease produced from the prostate. It is measured in blood. So it spills in blood, and so it can increase in malignancy or cancer, increase in infection, inflammation. It can also increase in hyperplasia. Somebody has got 110 grams prostate, please see your PSA. It will be 5 or 6 or 10. Don't panic, please. If somebody has got a 200 grams prostate, his PSA will again be 5, 6, and 10, and not less than 4. So please don't panic, please. In other words, don't correlate a report and get it treated. That's not the way it happens around. We don't treat reports. Patients today actually carry thick files, come to the OPD and start presenting files to me. I said, we don't need those gifts. The gifts are your language about your urinary health. And I ask them those questions, which my urology colleagues do in every hospital, every city, and every state. They ask you questions about your urinary complaints, day and night. Are you getting multiple times at night? Are you falling down at night? Are you not able to empty? Your flow is good in the night, good in the morning, poor flow, emptying, etc. Then we look at examining them. That means you lie down on the bed, we look at the undergarments, we look at that you don't have a phimosis or a skin being tight, etc., etc. And then we go forward around. So PSA comes a little later, but probably people bring about 5 PSAs of 5 years and show me PSA. I said, your PSA is normal. Now, let me tell you a very defining statement today. A normal PSA does not mean you may not have cancer. A normal PSA, 0 to 4 nanogram percent, does not mean you may not have a cancer. In other words, a very high-grade cancer will still be present with your PSA being normal. So will you sit with PSA home every year till one fine day you have a metastatic high-grade cancer? No. So remember that a PSA between 0 to 4 and you have a very high-grade prostate cancer, the PSA will continue to be normal. Why? Why does it happen that a very high-grade and a very severe kind of a prostatic cancer may not raise the PSA? Because PSA is produced from prostate cells. If the prostate has undergone such a massive derangement in its cells, it's a very high-grade prostate cancer, PSA may just not be produced. You may have still very low levels of PSA, and it is not very uncommon. I would say once in 10 to 12 weeks, I see one prostate cancer. It was picked up by me, picked up by a urologist in your city, where he examined the prostate and felt abnormal. Did a PSA and PSA felt normal. Did a MRI and a CT scan and PET scan, it showed it has spread everywhere. Did a biopsy and found it's a high-grade prostate cancer. So in other words, don't rely on the PSA alone and be happy about it. Don't rely on the PSA and get worried about it. That's what the question today is. So PSA is not your domain as an individual, as a learned individual with a lot of respect in the society. Your job is to leave it to the specialist of the art called the urologist in your hospital, in your city, for let him do it. You don't fly the plane. You sit in a business class, economy class, and probably enjoy the plane ride. Let the pilot do his own flying through the clouds and through the sunrise and telling you left side is Bhubaneswar, right side is Vishakhapatnam, etc., etc. So we don't drive a plane. We better enjoy the plane ride. So for you, PSA is quite a surrogate marker and a slippery slope to think about. Leave it for the specialists of the art. Coming to the end of it, friends, what do? We do a medical history, ask you a lot of questions, ask you your relatives who come with the reports filed from different cities. We do a very directed physical examination looking at you have no neurological issues, you have no constipation, which is a very common phenomena, and constipation worsens your urinary issue. We examine your prostate, we feel all about your prostate, look at your genitalia, look at your phimosis, look at nothing abnormal. Do a urine test. I told you urine test is always a midstream and a clean cat specimen. From tomorrow onwards, I hope a wake-up call where India wakes up and understands that we will not be giving a sample without cleaning up the external genitalia, be it a male or female. We'll pull our skin back. If the skin is not pullable, there's something wrong with you. See a urologist. You may be having a tight phimosis. And all diabetics land up actually getting a phimosis as an acquired phenomena. So if you're a diabetic today on a World Diabetes Day, and if the skin is tightening up gradually and tightening up too much, there's a possibility that you have got an acquired phimosis. A phimosis which are developed as a result of you being diabetic. Many a times, I don't need a blood test to diagnose diabetes. When I examine a patient in a directed physical examination after having taken a history, I find the skin is too tight, there is pus discharge, there is inflammation, there are cuts on the tip of the penis. Good enough for me to tell, are you a diabetic? And he says, no, I never tested, but I'm not a diabetic. I say, please go and test. You are an uncontrolled diabetic. In other words, as a urologist, we can tell about diabetes by looking at the penis in terms of your skin being too tight, of recent onset, progressive, infected. The skin is all inflamed and infected. So that's how, even if we are low in the alphabetical order of U for urology, we pick up things earlier than you. And therefore, it's nice to see a urologist in your city. PSA testing. We look at total PSA to start with. Now, don't go into a free PSA and a PSA ratio, which is only about a calculation that you won't understand. A total PSA is what we normally do, unless we are in the gray zone of 4 to 10, or beyond 10, we don't do any more PSAs. We go into a biopsies or an MRI or whatever. And finally, the symptom evaluation, which is by an IPSS symptom score. If any of us in the audience today feels that I have no urinary complaints, I have heard, I will go to Dr. Pandey only when there is a trouble. Please open up Google. Please go to this IPSS symptom score, International Prostate Symptom Score, IPSS. Open up the score and score yourself. And you will go yourself and find that you are in either the mild, the moderate, or the severe grade already. You can score yourself. So that's the way many a times we ask them to score themselves and identify which grade are you in terms of bothersomeness. Remember, the prostate issues is completely with the patient, with the audience today, and with the society, not with the doctor. Unless you complain, unless you come out of your homes, we will never know what is happening in your homes. Not the homes where you live in, but the homes on which your body lives in. And deep in the home, in the prostate, where changes are happening around. So your symptoms, either defined by the IPSS symptom score, called International Prostate Symptom Score, which you can check up on the Google today, look at your scores around, or your complaints, which is directly examined by your doctor, will help you. I've already told you that we look at all history, nature, duration, fluid, comorbid, prior, current illness, your surgeries in the past, etc., trauma and current medications. We also look at regarding your sexual function, lower tract symptoms. Men are hesitant to talk of men's health. We are on the edge of International Men's Health Day, which is just coming up. We're looking at International Men's Health Day, and all men need to be empowered on that. So we're looking at the urinary and sexual issues completely. We look at the medical history. It assesses all this, what you are going through, number one. What medications are you taking? And I just want to give a sentence out here. Friends, we are just close to the time we want to complete and take your questions, but just few more important topics. Why would you continue taking a drug, any drug you know for prostate, Urimax or Flotral or Alpha, whatever names do come in, continuously without knowing the effect of the drug? And therefore, to know the effect of the drug, we need to have a Urophometry. We need to have an assessment by a urologist. We need to have a sonography. We need to have a PSA. And these, though, are done yearly anyway. If you are on a medication not improving, there's no point continuing a medication. If you are taking a medicine regularly, and if you stop the medicine for 2 days and urine doesn't come out, please stop it completely. Go and see your urologist. You are not going to be dependent on medication and still not improve. The medicines sometimes go on long, sometimes go on for lifetime, but that is what a urologist decides. We can't be blindly taking medicine for 10 long years and one day undergo a surgery. That means we missed the boat where the obstruction was progressive and changing. This is very important for us to wake up to the phenomena. As I told you, we will have a mild, moderate, or a severity of symptoms. which people complain both on urinary and sexual issues, and we look at it. Physical examination, which a urologist always does, is a digital rectal examination to assess the prostate internally. He looks at your bladder. He looks at all the other motor and sensory phenomena, examines you and looks at whether you have got a neurological issue, whether you've got a spine issue, whether you've got other issues too, or you have a constipation which contributes to the problems in urinary flow. If you are a diabetic, and I know many in the audience today could be diabetic or their relatives could be diabetic. Diabetic people undergo sadly a change very gradually, both in long-standing diabetes and in uncontrolled diabetes. Something like you go a diabetic retinopathy where the eyes lose power. You undergo a diabetic nephropathy where kidney undergoes a change and possibly both the kidneys can be lost, which is called as end-stage renal disease or diabetic nephropathy. Similarly, you undergo a change called diabetic gastropathy where the stomach moves slowly and you cannot pass the food down. You develop something called enteropathy, or the bowel doesn't move and most of you are constipated. Diabetic people produce more urine at night and all through the day and night. They go through the polyphagia, polyuria, and polydipsia technology. They also go through a change in urology, which is called diabetic cystopathy. Diabetic cystopathy. I've spoken at length on my YouTube channel on diabetic cystopathy. Just to give you a lead on that, if you are a diabetic for more than 10 years duration, or if you are an uncontrolled diabetes of long standing, the bladder undergoes a change. And what is the change that the bladder is normally doing? The bladder normally relaxes and contracts. It relaxes to empty, to fill the bladder, which is coming from the kidneys, and contracts and pushes urine out. This is a cycle which it maintains all through the day and night to give you a continence or a control, which sometimes leaks out if there's an obstruction or the bladder is overactive and you leak urine again and again. Now in diabetics, the bladder's inner lining or sensation can gradually go down, and the outer lining, which brings about a contraction, can also go down, which is called diabetic cystopathy, or a weakness called underactive bladder. The bladder is not overactive, which happens to people where the bladder is contracting more and making you run. The bladder doesn't have much sensations. That can happen in diabetics. And that's a sad story, because if you become 80, you cannot become 50 years old. If your gray hairs turn white, they cannot turn black anymore. If your bladder undergoes an activity which becomes underactive, it cannot become overactive or active anymore. That means your bladder turns weak. And once you're weak bladder, it becomes a difficulty for us to examine. So therefore, all diabetics need to see either diabetologists, their family doctors and physicians, and maintain their diabetes week after week, month after year, year after year, and decade after decade. Diabetes is a harbinger of very silent changes and a very ominous disease. Therefore, don't just treat your blood reports. Look at a quality of life change in diabetics. Look at your physical activity. Look at your examination. Look at your health. Look at the overall health. And don't postpone your eyes, your kidneys, your constipation and diabetes. You're getting up multiple times in nocturia, and your diabetic cystopathy, a very silent change. The day you wake up, you will have a urinary catheter, which will be too late. Therefore, to come to the close of it, obstruction to the flow of urine is an important aspect which develops very gradually till one fine day a shower which was pouring well can gradually come down, and you will strain to pass urine. Don't pass urine, pass with a thin stream. And that is where the wake-up call today was, where prostate is trying to bring about a blockage in the urinary passage. The passage is getting blocked, which was broad. And that is all which is the talk for today. We will do a urine routine and culture. I told you how to do it. We'll do a sonography and assess the bladder wall thickness, the amount of urine left in the bladder, look at the prostatic size, look at the changes happening in the kidney. But I said Urophometry is a stronger investigation, something which tells a reality more than the sonography. It tells your flow, it tells the changes, and tells about how much neglect or knowledge, not knowing, or postponement which has happened while you have been taking medicines or not taking medicines. So a measurement or a follow-up is almost required. And finally, a PSA, which is a total PSA, and that has to be evaluated in the light of a clinical examination. So just seeing a PSA and sitting on a high-grade prostate cancer is not a good idea. Just seeing a very high PSA during prostatitis or after retention of urine and probably getting panicked around and calling me up also is not a good idea. So PSA is a silent test. It's a test in the cold, like today, on a day which we are celebrating as a Sunday or a Children's Day or a World Diabetic Day. Doing your PSA in a cold rather than in a hot situation is important. Prostate undergoes enlargement in all directions, but can also enlarge from the base into the bladder. Like a Qutub Minar, it can grow into the bladder and cause a mechanical obstruction. Out there, the medicines will not work if there's an obstruction to the flow. We do a Urophometry. When we see this kind of an ultrasound report that you carry, or you carry this kind of a report, the black thing is a urinary bladder. That's a urinary bladder. And your prostate can sometimes, which normally your prostate is actually here. But sadly, the prostate is growing in all directions, is also growing into the bladder like a Qutub Minar, which can grow. This is just a configuration to tell you that prostate can grow in all directions and can cause a trouble. And these kind of prostatic enlargement, which are causing an obstruction to the flow, necessarily need a surgery to carve out the prostatic fossa. When we do surgery for prostatic enlargement of BPH, like a TURP or a holmium laser or a laser prostatectomy, we remove the prostate only from inside, friends. We don't remove the entire cancer prostate. Here, we have the prostatic enlargement only. When you have a cancer prostate which is localized, then we remove the entire prostate completely, including the shell. Giving you an example of a coconut. A coconut is what you eat internally and you leave the shell. That is what is a prostate surgery for an enlargement of prostate, called a TURP or a laser prostatectomy. We leave the shell or leave the walls of this room and remove the things from inside. We create a passage for you to pass urine well, because the urine was getting blocked, or was not treatable medically or failing treatment medically. Then only we operate you. Otherwise, we don't operate you. So be prepared to jump the gun and probably get yourself aware in terms of the health being taken to such levels where Health 2021 and prostate health in International Men's Day, which is coming soon. At the same time, men's health did not get neglected. But prostate cancer in a localized disease, I remove it by a robotic route. I remove the prostate cancer completely and join the bladder to the urinary passage for urine to come out freely. So in a prostate cancer of localized disease with an intention to cure, we remove the entire cancer. In a prostate cancer which has spread, we have hormone manipulations and treatments available. In a prostate cancer which has spread and is causing a blockage to urinary passage, we still do a channel TURP and open the passage to pass urine well and give you those hormone-related medications to shrink the spread of the prostate cancer. So there are many ways to treat. Once you've undergone a prostate surgery for a BPH, that is for enlargement of prostate, which is a TURP in your earlier days, you still can have an enlargement of prostate in future. That's what I want to wake you up. So don't think that it is done and dusted forever. When you cut your hairs and probably look very good for yourself, you will actually have a18th of hair again in a month or two, and you will go back and get a haircut again. What does it mean? There are changes happening in the body, which is subject to probably repolishing or a refurnishing around. So prostate similarly, because of your male hormones, undergoes a change again. So there's a possibility a decade later, you may have a prostate which could enlarge and block you or bleed you, and we may have to operate you again. So prostatic enlargement, which could happen gracefully with age, even after prostate surgery, can be treated medically. And therefore, you will be on an annual follow-up after your prostate surgery with your urologist all your life. So why not be friends with your urologist in your city and see that you are getting treated properly? Friends, I come to a close. I bring you salutes and greetings from Team Koklam and Dhirubhai Ambani Hospital Urology Department, where my colleagues, Dr. Bijoy, Dr. Ismail, and the entire wonderful team of urology team who takes care about the change that I'm just speaking loud and clear to you as an ambassador to the whole subject. Change is what is a bend in the road which you can negotiate. It's not such a difficult bend that you can't negotiate. I think we need to partner you on these kind of platforms and take it forward. As I come to a close, I understand that it's time that we always had miles to go, and then came COVID. But what got us here will never get us there unless we wake up to this phenomena of taking it forward to the highest level. Friends, I come to a close of a session which was a monologue. They always say the good news is we know more about our prostate. I love my urologist in my city where I know more about it. I will do my health checkups. I will go my complaints to my doctor and probably get sorted out. So friends, age is no bar. From late 40s to 80s, you could have a prostate change. Presentation can be many. It could be a presentation in the cold when you have a complaint, or you could probably pick up one by your health checkup, which you do annually. Or if you have a complaint, don't postpone. If you are on a medical management and not improving, don't postpone, see your urologist. And if nothing is so, then please don't let an emergency happen. And that is how you love your urologist in your city. I come to a close, making you enthused that prostate changes will continue to happen very silently. The good news is you are empowered, you know about it, and you can only do better and better with passing time. Friends, I've overshot it because I started late. If you have any questions, can you just pass it on to me here? Or if there are no questions, I attempt to answer all your questions. By the way, I continue doing it for a lot of colleagues who come in around. So empower yourself in your cities and your towns. Enjoy yourself the way you have been doing it, but your enjoyment should not come as an emergency ever again. In other words, it is important to wake up to a phenomena where prostate health is undergoing a change. There were so many small points, from the way you give a urine sample, the time you see your urologist. You have a urinary complaint, please don't keep piling reports on that. See your urologist, get examined, get evaluated, get a Urophometry done, check your ultrasound reports, check your PSA in the silence, in cold. PSA always may not be the right marker. It's a surrogate marker. Very high PSAs can also happen with a very large gland without any problem. TSAs can rise dramatically and continue to stay risen all your life if there's a chronic prostatitis. TSA rise from even 4 to 5 cannot be taken lightly unless your urologist concludes and says, this doesn't look bothersome. So not that we do biopsy for all patients around, but then we look at identifying right patients in the right time, stratifying it and treating it. For a cancer prostate, we remove the entire prostate. For a BPH, we only do an internal carving or creating a space through the jungle or through the mountain to create a proper valley through which urine again comes well, and you in your 50s to 80s pass urine again like a child again on a children's day. And that is what my motto was on a children's day. Let's make every man a child again in his urination so that he can paint his urinary stream on the wall like he used to do across the border every time. Thank you so much for coming in such large numbers. I know many people could not have logged in for the kind of logging in requirements, but at the end of it, you all have done well to be here today. Thank you so much. The team, let me know if there's anything, because I've tried to complete everything in a short while and got all the questions and answers, making more people aware that we will not postpone our urinary health. And if that is done, we could come to a close.
So thank you so much, sir.
Sir, Arvind, are we done? I hope I've answered all the questions by attempting to bring about awareness on the slides. I'm more than sure we may not have many questions around. If there are any more questions, if there are any questions, let me know, please.
Sir, there is a few questions in chat box. One question from Mr. Mangesh. For how long patient is on bed after TURP?
Okay, so TURP is about creating a passage of urination in very specific indications for prostatic enlargement or occlusion. In other words, if you are refractory retention, if you have a catheter where you have got blocked, if your urine flow is very poor, even despite medicines, we don't only do a Urophometry, we go to the next test called Urodynamics. And once we do a Urodynamics, we pick it up that this man is having a bladder outflow obstruction. We do a TURP. We admit you an evening before, cover you with antibiotics. You must have passed motions. We give you all those preparations. You undergo a TURP, a surgery will last anything between 45 minutes to an hour on maximum number of cases. Sometimes it may shoot because of the size. When we operate you, that day we leave a urinary catheter or a pipe. That catheter is a three-way catheter which drains urine, and we also irrigate so that there's no bleeding or blockage to the urinary passage. And we let you for the first 24 hours being very closely monitored. Many patients go home on their 3rd to 5th day, so there's nothing to be in the bed. First day onwards, we ask you to get up. We give you laxatives and purgatives. We ask you to pass motion softly. For the next 4 to 6 weeks, the prostatic cavity is healing. We created a cavity by creating a space through it. Remember, the prostatic cavity is healing. At that time, I suggest we should not have constipation. We should not strain physically in motions. While doing so, you will do justice to a friendly neighborhood called the prostate, because the hard motions are coming to the rectum. A friendly neighborhood called the prostate, which has undergone a treatment or a therapy or a cure, is just the next door. And therefore, it is healing gradually by a lining developed. The catheters are normally removed from the 3rd to 5th post-operative day by everybody in the world. But there's a small subset of patients where we leave the catheter a little longer because the surgeon has seen changes in the urethra, in the prostate, and requires a longer for either the prostate and the urethral passage to heal to be left without a catheter, or sometimes because of issues of physical activities, health, elderly, friable, we sometimes keep the catheter a little longer. So the patients don't lie in bed beyond day 1. They all get up, they walk, they move out of the rooms, they become friends with other patients carrying catheters, and that is how they become ambassadors of the subject, saying that I underwent a prostate surgery yesterday, and day after tomorrow I'm going home perhaps. Obviously, we look at the safety, we look at who is doing well, and accordingly remove the catheters from 2nd to 5th post-operative day. And then patients go home, they follow you up. After that, with the Urophometry, with the residual volumes, with the residual complaints, if any, they're on medicines for a short while, we de-escalate. And that is how we have taken somebody from impossible to possible, finally treatable and curable. So they are treated, they do well in terms of urination. So you don't stay long in the bed. You almost never stay in the bed other than the first night, which you unfortunately don't sleep also because urination, water change, etc., etc.
Thank you, sir.
Anything else, Arvind?
And sir, second question is from Mr. Nitin. What are the chances that the cancer has spread beyond prostate? If so, is it still curable?
So I think I answered Nitin's question already, but that you have a question just to replenish it again before we come to a close on the last 2 questions. Yes. What are the chances? Chances always are. And I told you in the era when there were not good imaging techniques, in the era when I was training at CMC Vellore and Jaipur Pondicherry in urology, and then I was at Chennai and Ramachandra Medical College University as an associate professor for a decade, I saw people coming late. Late means the disease had already progressed, or probably the awareness was missing. That can happen today too. It can happen every day in locations where people are not aware, or probably we have not percolated so much into the hinterland of India. There's a huge possibility that the prostate cancer can be spread, and that's no worry. If somebody has to be necessarily getting a cancer, in terms of a cancer to lena hi padega, choose a prostate cancer. Why? Because prostate cancer can be manipulated in many ways by a urologist. It can be removed completely. It can be manipulated even if completely spread. So yes, your question is it could be spread in some cases. The other cancers are all deadly in terms of requirement for chemotherapy, radiotherapy, surgery, spread, death, etc. Prostate cancer is one where we can handle all that thoroughly well. So prostate cancer can spread beyond the prostate and to organs, which could be lymph nodes, which could be liver, which could be brain, which could be the mediastinum and lungs, and etc. etc. If that happens, we may only treat the prostate internally to create the passage, but we could use a radiotherapy for still a localized disease in the pelvis. We could do a massive hormone manipulation and bring about shrinkage of all these metastatic sites around. We follow that up with PET scans and look at what is happening. So don't panic today because you have only one life to lead. You have only one body in which you will lead. And you got to continue polish the body even if you have got disease. Sadly, there are people who have disease despite we talking about awareness and curing, who don't know about themselves. So if there is a cancer of prostate, if you panic, you may not do wonders. You probably take your steps forward. Your urologist in your city will handle you. In other words, he will do all needful to get you the graceful aspects of the post-treatment scenario. Therefore, the surgery could be one aspect, hormone therapy could be second aspect. We also have late therapies in terms of chemotherapies or radiotherapies to spread areas too. So prostate cancer is truly today much more empowering than any cancer in terms of identifying it early or sadly late stage. Early localized, completely cure, late can still be treated thoroughly well. So don't lose heart around because people very late in the age and very late in the spread, both can be treated. If not completely cured, they will continue to live and live stable.
Thank you, sir. Sir, one more question is from Mr. Pradeep. How you will select molecule that is LHRH agonist or antagonist for CA prostate treatment?
That's a good question. That's a technical question. But LHRH agonist and antagonist are looked at as two different modalities, finally taking the same path, finally giving the same kind of an end result because the lineages that they take is different. So we choose this depending on a lot of aspects. We also look at the newer molecules and look at the cardiac morbidity. But the cardiac toxicity has been so much now less with the LHRH agonists. So we look at that aspect around in cardiac patients, in a very elderly patients, when you want to shrink the gland and have a more dramatic relief. Otherwise, LHRH antagonists have been for decades together with us, have done a wonderful job. So foundation on LHRH antagonist has been extremely strong. On the backdrop of that, we stand taller today with LHRH agonist having those niche areas and those aspects of, but that's too technical that an oncologist or a urologist would decide based on a spread of a disease. Yes, we look at cardiac toxicity as an important toxicity on those patients who deserve to be looked at on the long term. And therefore, agonists score a little bit over antagonists, which have had a longer period of time and have equally good results. So in other words, my language to a very common man could be non-technical is that khana muh mein jana chahiye, wo chamach se jaye ya fork se jaye ya spoon se jaye. Finally, you have to get well. Similarly, the spread disease, which Pradeep has asked about, can be handled with two very strong kind of molecules we have. Both may have a different mode of action, but they finally treat you, cure you, stabilize you, and keep you stable for our aims and promises of years or decades.
Thank you, sir. And there is a one more question last, sir. Which agonist you use and how will select for patient?
So I will not go deep into that today because that becomes technical. We choose what kind of agonists and antagonists are available and we accordingly look into that. But we are spoiled for choice on both sides. On one side, we have got Degarelix as a wonderful new molecule which came 7-8 years ago. And we look at that as a monthly institution after an induction dose. On the other side, we have got the entire stuff of the older molecules which are palmorelins and all of them have actually done wonders to us. So that again, the choice is defined by the state, choice defined by the entire profile we create. And therefore, that is what is called staging. We stage it across and we look at which molecule to use. Now, I personally would not be putting a very extra kind of view, but each of our clinicians would have a different choice of molecules. It depends a lot on the evidence that they have, and we respect that evidence. We don't question and interrogate for them. So my colleague urologist, my colleague oncologist who look into advanced prostate cancers, Look at the entire profile. Like we have a portfolio created for your finance. We have a portfolio created of the disease and the stratifications. And accordingly, we look at the kind of molecules we look into that. So we have got a host of drugs today, and the drugs are wonderful. The choice of the drugs comes with multiple things. If somebody is coming from Assam, if somebody is going from Andheri, number one. If somebody is 80 years old compared to somebody who is 50 years old, how aggressive can you be? If somebody is very frail and lying in the bed compared to somebody who is in the prime of life and working and daily working and has to probably live his and probably continue to win his bread for his family. Somebody who has got a great score, somebody who has got a very high state disease and a high grade disease. So the choice is just not defined by one single aspect. And therefore I said that I'll leave fluid, because then I'll be naming drugs and molecules here. My job today from this wonderful platform created was to create an awareness, which we have not always done. The awareness was to look inward to yourself. The menace is internal. The menace, which was possibly a gland, which was silent and when you were young and did not know much about it, could become a menace. It could be no trouble for some people around, but many of them go through change. If you can identify the change in time, you possibly will deal with it well. And that's where you will be in partnership with your urologist and pick up things well. Just being on a medical management and not assessing yourself and blindly taking a medicine is the biggest crime that we will do to ourselves and to our elderly gentlemen and to our parents, rather than just not leaving them alone. So it's important to continue assessment while you're in medical management, because not everybody will continue to take medicines all their life. There are medicines which are de-escalated and reassessed. There are medicines which are removed and reassessed. There are a small subset of 2 to 10% patients where I've stopped the medicines because we achieved the endpoints where they were doing very well. I was happy with the Urophometry. Their prostate was shrinking to a size commensurate with them, and their age was such that they were on multiple medicines where my medicine may not be required. And therefore, it is important. Therefore, I said, friends with urologist, you love your urologist because he looks into doing A, B, C, D, and X, Y, Z for you in a disease, which he can treat medically. He can probably shrink the gland. He can treat you therapy-wise. He can stabilize you and de-escalate it. Or unfortunately, the disease can defeat you and your urologist both, because disease is progressive. And that's where we will end up operating and giving you a cure. Therefore, you're not on the medicines all your life because you get a cure. That you and I don't decide. It's decided by the set of investigation, your state and stage where you are in. If we have got doubts that the next step is you will fall down, we will evaluate you with a urodynamics beyond uroflow and identify and evaluate and probably tell you that we need to operate. So operation is no scare. Operation gives you a cure if it has to be done. I said medical disease get medicine, surgical diseases get surgery. Prostatic issue is both medical and surgical. BPH is both medical and surgical. With the revolution we have, we got medicines to treat you completely well if you come in time. If you come late, we can cure you, so we don't blame you for that. But you may not have known the problem, and that's why you come late. It's not the language that I normally use and say that you came late and sorry, therefore you pay the price. That's not true. And that's what no doctor will tell you. You came late possibly because of the pandemic. You came late because there were more pressing problems, or you came late because you did not know about the disease. That's how it is. And therefore, the knowledge sector, which is to be improved today and empowered today, is what was our domain today. Arvind, I think that was the last question. I have looked at attempting to do A to Z on this subject, and I'll continue to come over and possibly have these kind of aspects on awareness on kidney health, on urinary health, on sexual health, and International Men's Days. Men do suffer and suffer very silently, as do women and children. If you have somebody having bedwetting, somebody having nocturia, women having recurrent urinary infections, look at the kind of urine samples you give. It possibly is wrong in the sample, or a diabetes which has gone out of control, or there's an obstruction. We got to prevent recurrent urinary infection and urinary leakage in women, which also is a very large domain of a urologist where we treat women. So it's not only men we treat. All women with urinary complaints need to see their urologist in time. Many times they see our colleagues called gynecologists, but gynecologists are deeply involved 24/7 in gynecological job, and many a times they may miss out your urinary complaints. Women go to gynecologists, or women go to women to get it sorted. But that's again a wake-up call that urinary complaint, don't always look at, I only want a female urologist. All women may not do urology, but all men who are urologists do treat females too. So see a urologist for urinary complaints besides the gender. It could be males, females, it could be trans, everybody. Friends, I'll draw it to a close. Saluting all of you in the audience. It could be even few or many. I look at this kind of awareness from you to the society so that you could help many more people to get it forward. For all those who may not have heard me before or who could hear me again, I have a YouTube channel on awareness on these aspects, which I continue speaking. And the platform that Arvind and the entire Dr. Reddy's lab have created today is a salute to the kind of work that our colleague urologists do across the country. I speak on behalf of all the urologists in our department of urology, and all the urologists and doctors who take care of urinary health for you. And my salute to all the physicians and general practitioners who actually treat prostate issues across the breadth and length of this city, right from Nariman Point to Vapi and Daman and Valsad, right from Malad and Borivali to Andheri. I know that they all do a wonderful job 24/7. As a urologist, we'll end up seeing only the tip of the iceberg. But now that more and more people are aware, they will go to their doctors, their family doctors, the general practitioners, and would request and would look at evaluation and get it treated, and maybe jump the gun if the results are not happening and see the urologist. I come to a close. Thank you again. Have a great Sunday. Have a great Children's Day, and be a child again in urinary flow if you identify yourself in time. Thank you so much.